Welcome to Dermatology Discussions. Today, we're going to dive straight into an explainer on Pemphigus foliaceus, which you'll often hear called the superficial blistering disease. Now, this is a condition that is absolutely crucial to understand, not only because it's so clinically distinctive, but also because it is highly tested. So let's get right into it. Okay, let's set the scene with a real-world clinical scenario. Imagine you have a 55-year-old patient who walks into your clinic. They've got this several-month history of a really red, scaly erythematous rash, mostly on their face, their scalp, and upper chest. But here's the catch. When you actually examine them, there are absolutely zero intact blisters to be found, and completely zero oral mucosal lesions. Nothing in the mouth. So what's the diagnosis? Well, our mission in this explainer is to crack this case and help you perfectly distinguish this condition from its incredibly sneaky mimickers. To get there, here's our game plan. We're going to start with 1, the clinical foundation. Then we'll move into 2, biology and desmogleins. Next up is 3, histopathology and differentials, followed by 4, diagnosis and management. And definitely stick around for section 5, which is a high-yield board review to quickly test what we've just covered. All right, let's build our base with section 1, the clinical foundation. So the absolutely crucial thing to know here is that Pemphigus foliaceus, or PF, is an autoimmune blistering disorder, and it's caused by a loss of adhesion specifically in the superficial epidermis. The number 1 hallmark you've got to commit to memory, it's the complete sparing of the mucous membranes. You see, because these primary blisters form so incredibly close to the surface of the skin, their roofs are literally paper thin. They're extremely fragile, meaning they rupture almost immediately. That is exactly why you're rarely ever going to see an intact blister on a patient. Instead, what you see are these well-demarcated red erosions and scaling that kind of look like cornflakes crusted onto the skin. And remember, this is typically a disease of the skin only. No mucosal involvement. Moving right along, let's explore section 2, biology and desmogleins, so we can figure out the why behind this disease. To truly wrap our heads around this, we need a quick refresher on normal skin biology. I want you to think of the epidermis like a brick wall. The keratinocyte cells? Those are your bricks. And the specialized intercellular junctions, which are called desmosomes, those act as the mortar holding all those bricks tightly together. Desmosomes provide that heavy-duty adhesion our skin needs to act as a cohesive physical barrier. Now, when there's an autoimmune attack that causes a loss of this vital mortar, we get a process called acantholysis. This literally just means the cells are losing their connections and essentially falling apart. Now, what's really fascinating here is the specific type of mortar we're dealing with. The key adhesive proteins inside these desmosomes are a family of glycoproteins known as desmogleins. And there are 2 main players you need to focus on. First, you've got desmoglein 1, or Dsg1, which is heavily dominant in the superficial layers of the epidermis. Contrast that with desmoglein 3, or Dsg3. That one is prominent in the much deeper layers of the epidermis, and it's actually the primary adhesion molecule in our mucous membranes. Keep this regional map locked in your mind, because it's the secret key to unlocking this entire disease. And this regional map perfectly sets up what we call the desmoglein compensation hypothesis. It's actually pretty brilliant. Down in the mucous membranes and the deep epidermis, both Dsg1 and Dsg3 are hanging out together. If an autoimmune attack specifically targets Dsg1, like we see in PF, well, Dsg3 simply steps up, compensates for that loss of adhesion, and completely prevents blisters from forming in those deep and mucosal areas. It's like having a backup generator. But up in the superficial epidermis, Dsg1 is pretty much doing all the heavy lifting on its own. There just isn't enough Dsg3 up there to compensate. So the superficial skin blisters and falls apart, while the mucous membranes stay totally protected. So let's quickly trace the exact sequence of this attack. Step 1, the patient's immune system goes rogue and produces pathogenic IgG autoantibodies that specifically hunt down and target Dsg1. Step 2, this binding directly jams up the works, causing desmosomal dysfunction. Step 3, that loss of cell-to-cell adhesion kicks off acantholysis. And finally, step 4, because Dsg1 is all concentrated superficially, the cells separate right at the very top of the epidermis, forming a classic subcorneal cleft. That extremely superficial split, that is exactly what gives PF its fragile, crusted, cornflake-like clinical appearance. All right, let's transition to section 3, histopathology and differentials. Okay, pay attention because this right here is the ultimate examiner's trap. This is the rule of contrast you absolutely have to memorize. You need to be able to distinguish Pemphigus foliaceus from its much more dangerous cousin, Pemphigus vulgaris, or PV. In PF, like we just talked about, autoantibodies target Dsg3. This gives us a superficial subcorneal blister, crusted erosions, and, say it with me, absolutely no mucosal involvement. In PV, on the other hand, the autoantibodies target Dsg3. Because Dsg3 is the main player in the deeper epidermis and mucosa, PV causes a deep, superbasal blister, big intact flaccid bullae, and it almost always features really severe oral mucosal involvement. Sparing of the mucosa is your ultimate, undeniable clinical discriminator for PF.
With that distinction crystal clear, let's move to Section 4, Diagnosis and Management.
To actually lock in your diagnosis in the real world, you're going to use a systematic 3-step approach. Step 1 is routine histopathology, your standard H&E. You'll take a punch biopsy directly from the edge of a fresh lesion to look for that characteristic superficial subcorneal cleft with acantholytic cells. Step 2 is direct immunofluorescence, or DIF. This is a big one. You have to take a separate biopsy from normal-appearing skin perfectly adjacent to a lesion, definitely not from the blister itself. Finally, Step 3 is serology. You'll order an ELISA blood test to hunt for those specific circulating anti-desmoglein autoantibodies.
Let's look a little closer at Step 2, the DIF, because it's pretty iconic. What we're looking at here is the classic fishnet or chicken wire pattern. It literally looks like glowing chicken wire. This represents intercellular IgG and C3 depositions seen all throughout the epidermis. It's the absolute gold standard finding for pemphigus. But, and this is a massive but, this exact fishnet pattern looks perfectly identical in both Pemphigus foliaceus and Pemphigus vulgaris. It confirms you're dealing with a pemphigus disease, sure, but it doesn't differentiate between the two types. You're still going to need your clinical findings and your serology for that final piece of the puzzle. So, once you've nailed down the diagnosis, how are we actually treating our patient? Well, for mild, localized disease, you can often get away with high-potency topical corticosteroids. But for moderate to severe disease, systemic corticosteroids are still a major backbone of treatment. However, the thing that has really truly revolutionized treatment lately is rituximab. It's an anti-CD20 biologic, and it is now widely recommended as a first-line therapy. Patients are achieving these incredible, durable remissions with it. We'll also frequently use steroid-sparing agents like mycophenolate morphital or azathioprine just to keep that long-term steroid exposure as low as possible.
All right, time to shift gears. Welcome to Section 5, High-Yield Board Review. Let's do some rapid-fire active recall to permanently lock this knowledge into your brain. Okay, question number 1. A patient presents with crusted scalp plaques and no oral lesions, and they get a biopsy. What finding is most likely? Is it A, a subepidermal cleft, B, a superbasal cleft, or C, a subcorneal cleft? Take a quick second to lock in your guess. And the correct answer is C, a subcorneal cleft with acantholytic cells. That is your classic, characteristic histopathologic finding of PF. Just to recap why the others are wrong, a deep subepidermal blister with eosinophils would actually point to bullous pemphigoid, while a deep suprabasal cleft would be our mucosal-involving nemesis, Pemphigus vulgaris. Nailed it. Let's hit question 2. Which finding best distinguishes Pemphigus foliaceus from Pemphigus vulgaris? A, Nikolsky's sign, B, target lesions, or C, absence of mucosal involvement? Think back to that central trap we talked about earlier. You guessed it. The answer is C, absence of mucosal involvement. It really is the single most critical clinical discriminator. Now, a positive Nikolsky's sign, which is where lateral pressure on the skin causes the epidermis to just peel away, that's a great test, but it's positive in both PF and PV. Mucosal sparing is your definitive clue for PF. Awesome. Let's try question 3, focusing on that diagnostic gold standard. What is the classic direct immunofluorescence, or DIF, pattern for Pemphigus foliaceus? Try to actually picture that glowing slide in your mind.
The answer is intracellular IgG and C3 deposits in a fishnet or chicken wire pattern. But remember the caveat, right? While this beautifully confirms a Pemphigus diagnosis, it does not differentiate PF from PV. They both light up with this exact same pattern.
All right, last question. Let's bring it all home. Which serologic ELISA profile is most characteristic of classic Pemphigus foliaceus? Think about those specific protein targets we mapped out. Spot on. It's positive anti-Dsg1 and completely negative anti-Dsg3. Because Dsg1 is dominant way up in the superficial epidermis, those specific antibodies cause those superficial crusty blisters. And that negative Dsg3 profile That explains perfectly why the deep layers and the mucous membranes are completely spared thanks to that compensation mechanism. But it definitely makes you wonder, what would happen to a patient's clinical presentation if their immune system suddenly developed autoantibodies to both Dsg1 and Dsg3? I hope this explainer made the really complex biology and diagnosis of Pemphigus foliaceus incredibly clear and accessible for you today. Like, share, subscribe for more content like this.